to spend the next hour and a half with us as we have a heartfelt discussion and engagement on a very important and a topic that speaks to most of us, I think, working in healthcare profession. So the topic this evening is communicating under pressure, supporting children and families across care settings. So we welcome you all this evening, and we will talk about a program in a few minutes. But firstly, I'd like to just introduce our team to you that is going to be a part of the webinar this evening. Our Patch webinar team is myself. I'm Tracy Rawlins. I'm the Patch SA Education and Training Manager, professional nurse, and then qualified in pediatric and adult palliative care. And Sue Boucher is my colleague, and her and I work very closely together on a daily basis. She's our program and communications manager, and she's going to discuss a little bit and tell you a little bit more about Patch and our courses that we offer. Then we're very excited to have both our chairman and our vice chairman of Patch joining us this evening as part of our team, Dr. Samantha Govender. She's going to be introducing our guest speakers as they present. And then we thank Busi for also being here this evening, and she will do the closing. So just a few ground rules for our webinar. We just ask that you all put yourselves on mute throughout the webinar. It just helps for any disruptions. And then if you have an opportunity, if you'd like to introduce yourself in the chat, we'd love to know your profession and where you come from. And then we'd like to also send out a special welcome to numerous international participants. And I think we even had a few join earlier just because of the time differences and frames. So we thank you for your patience and for being here. Should you have any questions or insights during the presentation, please post them in the chat, and they will be monitored. Then we will pose these questions to the presenters at the appropriate times after their presentations. And then at the end, please do stay on and complete our online survey. Sue will put it in the chat, and then you can either scan it from the last slide that's presented. But it really does help us going forward with what's being asked, how we can improve our webinars, and just to find out who is participating. So thank you for that. Then just to say our program, it's quite an in-depth program, long, so we thought we'd sort of allocate timeframes. But just to say, we are going to have the welcomers now. Then Sue will talk about the launch of the Patch SA EMS online course, and she will welcome and introduce our speakers. Dr. Sam Govender is going to share a word or two with you, and then introduce the presentations. There will be a Q&A time after each of the presentations. And then thank you, Busi. She will wrap up the program, and then please at the end complete our survey. So I'm going to hand over to Sue to talk a little bit about our Patch Academy.
Thank you so much, Tracy, and welcome to everybody. It's really wonderful to have you all here with us. I just want to talk, before I introduce our wonderful speakers, I just want to talk a little bit. This webinar also forms part of the launch of a new online course. So just a little bit about Patch Academy. Patch Academy is an online course. We've got 14 CPD accredited asynchronous courses. That means you can do them in your own time, at any time. They're all CPD accredited for people who are registered with HPCSA. We have 2 free courses unless you need CPD points, and then we ask you to pay 100 Rand for this, just for the admin of those CPD points. We have 2 comprehensive courses, and that includes a 9-month course on pediatric palliative care that began at the beginning of this month, and then we hold 2 4-month courses on perinatal palliative care throughout the year. So one has already begun, and our next one begins in August. Just to say that we have undergrad med students from 4 universities now who have to take our introduction course. It's part of their curriculum. And so it just means that we know that doctors going out into the field have an understanding of pediatric palliative care. And since our launch in 2021, we've had 4,000 plus users who've taken one or more of our courses. If you could go to the next slide, Trace. And we're very excited to launch a brand new course. We launched it just a couple of weeks ago, and it's children's palliative care for EMS providers, emergency medical service providers. And it's something that is very close to my heart. I have a daughter who's a paramedic, and I just know that often people in EMS services actually have to do some of the most difficult, make decisions under pressure, and their communication under pressure is also so important. And it's one of the reasons we wanted to introduce this course. It's our 14th standalone course, and as far as we know, and as far as AI can tell us, it's actually a one of a kind. There are no other courses like this out there. It has been created in collaboration with EMS providers. I'd really love to say thank you to Dr. Caleb Gage, who was very helpful in helping us put this course together, as well as Jivanesh Chetty, Dr. Jivanesh Chetty. I'm not sure if you're on this webinar, Jivanesh, but huge thanks to you for your assistance as well. It's been accredited with 8 CPD points, 4 of which are ethics, which is great. And even better, we have a wonderful launch discount for you. So if you can purchase the course before the end of this month, and you'll get it with a 40% discount. And you can do it at any time after that. You don't actually have to immediately start it. So if you're interested in doing it, we really would encourage you to purchase the course while this discount lasts. And then it's going to be my great pleasure to introduce 2 wonderful presenters. We really feel very honored to have people of, who are so well versed in their field, and we are looking forward to hearing from them. The first one, if you go to the next one, Tracy. Our first speaker is going to be Dr. Caleb Gage. Caleb is a paramedic, a researcher, and educator with a focus on advancing out-of-hospital healthcare systems. His research primarily explores the integration of EMS and palliative care. He currently works as a program manager for the City of Johannesburg EMS and is the National EMS Coordinator for the Stroke Angels in South Africa. And he recently authored an open access journal article, which I know Caleb is going to refer to in his presentation, which is titled The Dynamic of Control, a qualitative analysis of perspectives of patients and family members with palliative care needs on emergency medical services. And our next presenter, who will is an old friend of mine. Prof Jan and I met many years ago. I was trying to think when it was, I think back in 2008 or 2009. And he is the head of Paediatric Oncology at the Universitas Hospital in Bloemfontein. He lectures at the University of the Free State for undergrad and postgrad medical students. He completed his 2-year fellowship in Paediatric Hematology Oncology and Bone Marrow Transplantation at the Sydney Children's Hospital in Australia, and he studied palliative medicine in 2013 and completed an MPhil in palliative medicine in 2016 at UCT. And Jan is also a long-standing member of the PATCH board, our steering committee originally, and now of our board. And Jan is also one of the most humble people that I know. When I asked him to send me a bio, he sent me this: Batuli born, captivated by Free State thunderstorms where few skies compare, and the quiet magic of starlit nights, an avid tennis player, a cat lover, and an ocean soul living inland. And that's just so young. But I just thought I had to show just a little bit more about him. Tracy, you show the next slide. And I think these are photos that I don't think Jan knew that I was going to share, but it's like when a picture says 1,000 words. That first picture of him with a snake was quite a few years ago, but as you can see, it was a wish of one of his patients that she gets to see and hold a snake. And as he said, he put all of his courage, he had to really put all of his fear aside and actually fulfilled her wish of seeing a snake. So that, I think, it tells you a little bit of who Jan is. And this is a recent photo that we shared on our Facebook post with one of Jan's patients. So thank you to both of you. We really appreciate your time and for sharing your expertise on this webinar. So over to Sam.
Good evening, everyone. It's actually really great to see a large number of colleagues and participants on this webinar. We've chosen this particular webinar because communication can be challenging in any setting. It can be challenging at home, it can be challenging at the scene, it can be challenging at the hospital. And sometimes you can go in with this mindset that this is how it's going to go, but it never ever goes that way. And sometimes it's even more challenging communicating with a child. So the purpose of the webinar is to actually help you find some pearls from the two wonderful speakers, to go out there and give you the tools to actually get to practice it in motion at work, but also say, I can use this versus I should change my way of how I do it, and things like that. So it was a topic that is quite close to my heart, and it's a topic that we've said we want to start our webinars with. And it's also a topic where I find challenging, especially communicating with children and children who want to know what's going to happen to them. So how do you actually do it? And sometimes you feel like you know, but when you are posed a certain question by a child, you're actually left dumbstruck and you don't know how to actually go forward. Or it's not the child, it's the... So how do you actually go about all of these things? How do you navigate these difficult scenarios? What is out there for you to help you deal with these scenarios at work? That's why we've got these beautiful, wonderful speakers, and I'm sure they're going to actually give us some insightful topics in intuition and pearls of wisdom to take with us when we go forth and manage our children and our patients and our families when communicating with them. So I hand you over to Caleb, and he's going to be sharing some wonderful topics and information with us now.
Sorry, I am there. There we go. All right. Can everyone hear and see?
Yes, we can. Thanks, Caleb.
Excellent. Well, yeah, good evening, everyone. My name is Caleb. I am indeed a paramedic by profession, and I got involved in palliative care through my postgraduate studies in emergency medicine, actually, where I first learned about palliative care. And I just thought, in the EMS world, we really have so much that we can learn from palliative care. And I thought it would be great if we could integrate these two services. And so that is what my research has focused on over the past several years. And I must say, it really is a privilege to be here, surrounded by so many people involved in palliative care, and particularly pediatric palliative care. And I really do take my hat off to all of you. I used to think that being an EMS provider was, one of the most difficult things in healthcare because of what we have to deal with. And then I discovered palliative care. And then I discovered pediatric palliative care, which, you guys are involved in cases that I don't think I could handle. I think I would crumble. And so I'm really grateful for all of you and for all the work that you do. And it's really just a privilege to be here. And I feel somewhat out of place in a sense, because I may just end up being, preaching to the choir. But I hope this talk tonight will be at least a useful reminder of some things for us. Also very excited for the new EMS and palliative care course from Patch SA. I had the privilege to go through that, and it's really, really great. And if there are any EMS providers who have joined us tonight, I do highly recommend that course. You will learn so much that will change your practice, not just in palliative situations, but it will make you a better paramedic in general when you apply those principles to your practice. So, communication, and specifically communication under pressure. And really, there is so much that could be said about communication and different communication principles and how to apply them in different circumstances and so on. And since there's so much that could be said, I thought maybe it would be helpful to just take a step back and remind ourselves about an underlying principle within communication. Because the fact is that the situations we find ourselves in, particularly in palliative situations, can be very complicated. And there are so many principles that we've heard of, that we've learned. But the question does remain, when do we apply these? How do we apply them? When don't we apply them? What do we do? And when we're faced with these complex and difficult situations, especially under pressure, especially for us in the out-of-hospital EMS kind of environment where there's time pressure, limited information, one of two things happens. Either you get confronted with that situation and everything goes out the window, everything that you ever learned, and you're lost and you don't know what to do. Or we start using these principles of communication that we've learned as somewhat of a tick sheet. And we go through it mechanically and robotically, which is ultimately not really helpful to patients and family members who are faced with very difficult situations. And so tonight, I really want us to get to the heart of meaningful communication. What is the posture of meaningful communication? What is the attitude that we need to genuinely employ in order to communicate well? And my suggestion would be that if we get this posture, this attitude correct, that will help us apply principles well. And even if you've never received any communication training, you've never heard of any communication principles, if we get this posture and attitude correct, it will still help you meaningfully and beneficially communicate in these kind of situations. So the first thing to remind ourselves of is the definition of person-centered care, a definition that I'm sure most of us are familiar with. It's an approach that consciously adopts the perspectives of individuals, families, and communities, respects and responds to their needs, values, and preferences, and this is the important part, and sees them as participants in their own healthcare rather than just beneficiaries. That is something that particularly within the EMS we struggle with, because we tend to just come in, take control, solve people's problems. That's not really what palliative situations always need. And so a correct posture and approach when we come to communicating in these situations has to be to see the patients and family members as part of our team, as part of our healthcare team, And I would argue they are the most important part of our healthcare team. They are, in a very real sense, our healthcare team leaders. They are the reason that we are there. They understand their challenges so much more than we ever will. Even if you are the best listener, the best communicator, they know better than we do. And so that is the first starting point for a correct posture from a healthcare provider towards our patients and their families, to see them as part of our team. And I think that's something that perhaps not just difficult in EMS, but perhaps that becomes difficult down the line in palliative medicine as well. I stand to be corrected, but I can imagine that over time, with all the expertise that you develop in these situations, perhaps it is a temptation to start going into situations thinking that you know best, you've seen this before, you know what to do. And perhaps we lose sight of this, that these are our healthcare team leaders, as it were. So a person-centered approach has to underlie our communication approach. The next thing is we have to understand something of what these situations require. What do these patients and family members need? And this is where this paper that Sue mentioned comes into play, this dynamic of control, as we called it. And this was a study where we interviewed patients and family members who were undergoing palliative care, who had used emergency medical services in their care, which is always an interesting thing. Why do these situations, why do these patients call an ambulance in the first place? And so that's one of the questions this study aimed to address. And the overarching theme of what we found here from these interviews was this dynamic of control. So what we found was that these patients and family members expressed a sense of having lost control over their lives and over their situations. You know, they're struck with disease, some chronic life-limiting illness, and now life begins to revolve around that illness, and it affects them for the rest of their lives. So they've lost that control. They then expressed in many different ways a desire to regain some control, or to at least maintain what control they still have over their lives. And then we found that they experience positive healthcare, good healthcare, when control is given back to them and reestablished in their hands, when it's transferred back to them. But they experienced poor healthcare and poor communication when healthcare providers seemed to take more control away from them. And that was often done simply through communication, simply through EMS providers, for example, telling them what is going to happen, often against their wishes, versus the EMS providers who would come in, listen to them, hear them out, try to honor their wishes as best as possible. That was what they really experienced as positive care from the EMS. And again, this doesn't just have to be the EMS. They mentioned healthcare in general. And so this dynamic of control is what we were exploring in this paper. And control seems to be a real need of patients and their family members in these kind of situations. And so let the participants in the study speak for themselves. So speaking of this loss of control, this was a mother with a young son who had quite a rare congenital abnormality that resulted in continuous seizures all the time. And that was really difficult, many ICU trips. And she said, "I'm divorced and remarried. My first marriage didn't survive the trauma of my son's disability. So yeah, that was quite difficult. My dad has chosen to retire and he pays half of my son's fees. This places further financial burden on him, and he has had to take this into account and tailor his retirement due to this factor. In fact, if I remember correctly, her father had to come out of retirement to help pay for these medical bills. So even in retirement, you are not immune to these difficulties and to losing a sense of control over your life. So serious challenges that people are faced with." Then a couple of quotes illustrating how people in these situations want to maintain control or regain control. The first was an example of poor care from EMS providers, and it's quite a nice quote because it illustrates a literal need to regain control. I was getting so frustrated because I was worried about my husband. I was almost ready to jump in the ambulance and try and drive it myself. A literal desire to get in control of the situation. And then this next quote is something that I found so important to the way that we approach communicating with our patients and their families. This person said that we should allow the family to set the tone of the conversation. Give the family time to indicate where they are at in their frame of mind. And this came from out of a story of, again, poor EMS care, where the EMS came in and they took charge, as we are trained to do. So in other words, we took control of the situation without giving a thought to what the family needs. And we told them what we're going to do, step 1, 2, 3. And then they also started, in this highly stressful situation, they started joking and bantering with the family and with each other. And it was just a really inappropriate tone of communication that they took while this family is suffering. And so that was a very important quote here. Allow the family to set the tone, particularly relevant in pediatric palliative care. Don't go in trying to set your own tone of communication. Allow the family to do it. See where they are at. Some of them might be in a jovial mood. Some of them might not be. Some of them might not know anything of what's going on. But we need to first recognize what the tone that they are setting is and match them there. Meet the family, meet the children where they are at. Don't try and change the dynamic. Don't try and change the tone immediately. Just meet them where they are at in that moment. And so here's the quote that I mentioned. They came and they sort of treated him and tried to get him stable, but there was quite a lot of joking and bantering going on while they were trying to stabilize him. And this was a result of poor communication practice, a poor approach to these situations. But then there was also much positive response in these cases. The first one here, those EMS providers actually cried with me. They were absolutely amazing. Such empathy for people that they don't know. It touches you very deeply. And these EMS providers for this individual went above and beyond their normal duties and helped even through the admission process and explaining the condition in hospital to the family members. And that kind of communication with the family goes so far. It seems so simple, but it goes so far, just giving them a sense of control over the situation. And that's the next quote. They just make you feel that you're in good hands when they are so calming and competent and efficient. In other words, they have reestablished a sense of control. Everything is under control. It's not chaos anymore. They've come here and they've truly reestablished control. It's still a highly stressful situation, but they just make it easier in a big way. And so, in summary, what is this underlying posture that will really help us in our approach to communication? Well, it is a posture that approaches our patients and their family members as teammates, as allies in our healthcare team, and as we've said, as the most important members of that team. It is a posture that recognizes this dynamic of control and the needs for control that patients, children, and their family members have. Remember, they're suffering. They've lost so much control. Let's do what we can, even in communicating to them, to give it back to them, to make them feel that, first of all, we are in control, but that also we have the ability to empower them to get back in control to whatever extent is possible. And it is an approach that allows patients and family members to set the tone of communication. We don't go in there and take charge and assume that we know best. We first listen to them and let them set the tone of any communication that happens. If I could summarize all of this in one word, what is the posture that we should take when we communicate with patients and family members? It's one of service. We are there to serve them. We are there to help them. And this is something that extends beyond the realm of palliative care, beyond the realm of emergency medicine. It's something that I think we need to really focus on bringing back, is to recognize that we are not some God-send amazing health providers that are there to solve your problem. No, we are healthcare services. We are emergency medical services. Our approach should be one of going in and saying, how can we best help you? That's the approach. And I think that term service is something that we really need to focus on bringing back into healthcare. It seems to me that we have perhaps started to lose that somewhere along the way. So let's go in with a posture of service to these difficult situations. And as we do it in all of our different situations that we are faced with, we can start to have an influence on the broader healthcare services system. So thank you so much again for the time this evening. I am happy to take any questions and comments.
Thank you so much, Caleb, for that insightful talk. I really appreciated how you scenarios from experience of colleagues and you as well, because that actually mattered quite a bit. And when you said, let us meet the family somewhere in their journey and see how it goes for them, we forget that at times, you know. And you mentioned something that's quite very important, because sometimes we'll be busy resuscitating a patient, but we're talking about other things, and the banter is real, and we forget that sometimes it's not sometimes, it's always wrong to do that. And that's a real person out there, that's a family, and they just want your undivided attention to that patient and that family. I'm just going to see with my colleagues if we have some time for comments and questions.
We do, Sam. If anybody's got questions.
If anyone has questions, please can you put them in our chat box for us, please? For Caleb.
There's one from Philippa.
Okay, there's a question from Philippa. Philippa says, how do you balance waiting for a situation to evolve and sharing facts, which you won't be able to give sometimes?
I mean, it's a great question. I don't know if I can do justice answering it. I'm happy if anyone else jumps in and gives their thoughts as well. From the EMS perspective, I must say it's very immediate and in the moment. So often there's not time to wait for a situation to evolve. Sometimes we do just need to share the facts quickly. It really depends on the situation. However, one thing I would like to see, at least from the EMS perspective, is that we do actually, if it's appropriate in the situation, that we do wait for the situation to evolve and just see what happens, because that time of observation also lets us see where the patients and family members are at. So I think another key thing that I like to do in terms of trying to strike this balance between watching and waiting for something to happen versus talking straight away is ask questions. I try to remind myself, instead of just saying things straight up, let me try to ask more questions. So I think that's all I can say. I don't know if anyone else has any expertise and wisdom on that.
Thank you for that, Caleb. I'm not sure if anyone wants to answer or give more comments to what Caleb has just mentioned. But there's a comment from Lauren who says, I think we often forget that patients are experiencing this for the first time, even though we have seen it 100,000 times, and you are very, very right. Tracy mentioned she thanks Caleb. She's found that she says, I found that I have become more mechanical in my communication, despite a lot of experience. The attitude, posture of communication may get lost in the thought approaches like spikes, etc. But it's very helpful with the attitude of active listening and curiosity is the real foundation of communication. Thank you for sharing that, Tracy. You make a valid point. We do tend to forget, or we become just thinking that it's part of it, part of our life, and then the communication and the real point of the communication sometimes actually gets forgotten. Sometimes you have to take a step back and actually remember exactly what you're meaning, and the curiosity is actually real. Thandeka has mentioned, what are the biggest barriers to effective communication in high pressure healthcare situations? Caleb.
Yeah, so again, I mean, I can mostly speak from the out of hospital emergency setting, but the two greatest barriers are the lack of time. You know, if I want to implement something like spikes, I don't have time to do that. Things need to happen now. So there's a lack of time, but also a real lack of information. I will go into a situation, never met these people in my life. Perhaps they don't even know that they have palliative care needs, for example. You know, we've just met for the past 5 minutes. I have 5 minutes to gather information, and I have to work with that. So that's a big challenge. And I often wish, and I have done it actually when the time is appropriate, but I often wish that I had a bit more time to just sit down and have a nice conversation with my patients. But yeah, those are definitely the big barriers.
Thank you for that, Caleb. Yes, I do think sometimes in that high output or pressure settings, the spikes is not actually going to work. And you have to just do what you need to do in that scenario or in that setting. But like you have said, is to talk and to ask questions. And that is the most important thing. And actually remember that this is a mother, this is a father, this is their child, or it could be their parent or their uncle or their aunt. And all they want to hear is or for us to be as a compassionate, empathetic doctor who just wants to listen and give them that time. If there's any more questions to our next speaker, there are comments in the chat, and I'll just read that out for the it says, Lauren says, the fear and anxiety for patients and their families is real. Anxious people want to gain control, which can often come across as a difficult patient perspective, is important in these situations. And that is very, very true, Lauren. If our people and our patients and our families don't know, they do become anxious. And then we just say to them, this is a really challenging or a difficult patient, but we need to look into it even further, look into them even deeper, and give them an opportunity. Tracy has mentioned to Thandeka, I think we give too much information. In a crisis, I was taught to give the headlines, and the headlines should be patient-centered. Exactly, it should be patient-centered. And sometimes we too tend to go, but we always need to focus on the patient. Okay, I'm going to hand you over to Jan, who's a dear friend and colleague. If there's no more comments and questions for Caleb. Jan is an expert in his field, and he's going to share with us some insightful information on.
I think we've lost you, Sam. Jan is going to be talking to us about more in-hospital communication.
Hello?
We lost you, Sam.
We've got you.
We got you back now.
My network is so unstable. I'm actually not even hearing some parts of the conversation, so I do apologize for that.
Over to you, Jan.
Hi, good evening, everybody. Yeah, we just had my brother's wedding this past weekend at the most magical place in the Southern Free State, and we had a magical thunderstorm, and the night sky was the best, I think, in the world. So that's why I wanted, yeah, when Sue was asking me all these things, and it's like who I am, but that's who I am. That's where I grew up, and that's what happens as well. And that to me also says a lot about how you communicate, because it's actually quite an important role of your job to be able to communicate to patients. And we talk to them in a lot of different types of situations, newly diagnosed patients, palliative care. And the one thing my mom always reminded me, speak to them in a language that they understand. So don't be all medically and important. Because remember, this what you are saying to them is this might actually shape their whole entire life. I want to take you to, this is a patient of mine that this was his mother one night at his bedside, and this was nearing the end of life. I think the intubation is a little bit too much, but he was suffering. We fought a 7-year battle against stage 4 neuroblastoma, and there in the middle of the night, she was sitting next to his bed, and she was holding a Bible. And then she looked up and she asked that question, will my son be okay? What do you say to her if the answer is no? This is where I actually want to start. I want all of us to imagine of a conversation that stayed with you. Don't remember the medicine that happened. What was the conversation? What made that conversation difficult? More importantly, what do you think the family members remembered about this? I think, yeah, this takes a lot from you, because I think really they don't remember the medical detail. It's really how you made them feel. And yeah, I had a good testament about that. One of my cancer survivors, last year she entered medical school, so they were front page of the Free State newspaper at the time, because there were 3 girls from the same school that made it to medical school. And I read her thing, and she told her cancer journey, and I thought, well, okay, well, that's at least one way that I contributed to this journey. And then she started off with this thing that the way that I made her and her mom feel as soon as I walked into that room, that's the kind of person that she wants to be, and that's why she wants to be a doctor. So it is extremely important how you talk to your patients and how you make them feel in the situations. I think in the medical world, and especially for my poor medical students, they are doing exams this week. Pressure changes everything. We definitely do not communicate the same when you are under pressure. Your brain narrows, your words shorten, you forget your own name. Your humanity can disappear. And it is not intentional, but the pressure can actually make the communication so much harder. It changes It could change why you actually went into that room to talk to the patients. In the textbooks, and communication looks so structured. You do this and you do that, and then this will happen and that will happen. But in real life, these conversations happens 2 o'clock in the morning in a busy ICU where the alarms keeps on going off and the family keeps on looking at you for answers that you may not have. So there's lots of uncertainty that happens. So you need to understand the moment that you're in. I'm going to take you on another journey, and this is a journey that I'm currently still busy with. There's a gorgeous little boy who was mistreated and misdiagnosed by an esteemed ophthalmologist for a benign eye condition, underwent surgery, nobody sent any histology. And then he ended up with another ophthalmologist because that one wasn't available at night. And things just didn't happen. Like it should. She got sick. Her colleagues looked after the child, but they also didn't look after the child because it's not their patient. And to her horror, when she did the final story, it came back as a small round blue cell. And because the poor pathologist didn't know that there was an eye supposed to be amongst that mess, diagnosed them wrongly as a neuroblastoma. But in the end, it ended up as like so I've discussed him actually on many international forums. First the neuroblastoma, then the retinoblastoma forum, and we came up with a really, really good plan. And it's so much so that what I had to do with him was to give high-dose chemotherapy and then to follow by an autologous stem cell transplant. And this is where we met our first hurdle, because all I got from the medical aid was a screenshot that stem cell transplant is not a PMB for retinoblastoma. I'm like, yeah, for ordinary retinoblastoma, no, but for this case, yes. And I've given them literature and things, and they just didn't budge. And we kept on fighting and fighting. But in the meantime, the mother just kept on telling me, Profi, just trust. So my in the end, we did the stem cell collection or harvest through the state. I admitted him as a state patient, and the small little Free State Plattelandse dorpie that he comes from, the community raised the money for the Thiatipa, one of the drugs that was essential in his conditioning regime. And we couldn't do the stem cell transplant without that because there was an intracranial lesion, that's why we needed the Thiatipa. So we were still very much so, this is a fight, and we still believe that we can win, and we trust, and going to move on forward. But through our conversations with the international panels, immunotherapy came up as a possibility for treatment. And when we did the scan, and I already started motivating for the immunotherapy before I even knew that there was disease progression intracranially after the stem cell transplant this January, medical aid just kept on saying, no, this drug is not available in the country, so they're not going to pay for it. So we kept on fighting and fighting and fighting and appealing and things, but I was now running at the end. I was grasping at straws. There's nothing else that we could do. And the best of it all is that he still went to school this year. He went to play rugby. And if he didn't get really, really tired, and his mom did bloods through his local GP, and somehow they got an appointment at a very well and good esteemed retinoblastoma ophthalmologist, we wouldn't have discovered the dismal situation where we are in at the moment. The tumor has basically tripled in size, and there's leptomeningeal spread all along the spine and things. And he's actually currently being admitted in Welkom with all sorts of issues. So something shifted in this whole conversation that we had and things as well. And it wasn't just the medical situation that's shifted. I could feel it even in myself that emotionally, because one invested so much, there was a big shift. There was a big turn in what to do and how to do and things. And this is the questions that we've got now. Because she was sent home from Johannesburg, and obviously she asked me, but now what? Is he going to die? How long is it going to take? What's going to happen? And if we think of it, this is actually when communication matters most, when certainty disappears. Because I don't have answers for all of that. I probably do have for, yes, he's going to die, but what now? How? And yep, I think now back to, I'll get back to the story a little bit later. And what do families actually remember when you talk to them? They don't remember the protocol. There's many things that family will remember. They will remember who was calm, who was honest to them, who avoided them, who said their child's name. One of the parents of mine, she has a 16-year-old girl with quadriplegic spastic CP and now a malignancy as well. And she said to me the other day, thank you for giving me a name, because I was always known as Kelly's mother. Nobody in the 16 years in hospital used her name. And we need to remember these small little things. We need to give them space for hope. The tone of your voice, the fact that you're present, that makes a big difference. Back to, this is other questions, that mom's question, will her son get better? But that boy in that ICU bed, I remember the story of when he asked, will his parents be okay? And I'm going to come back to that because that Bible has got a very important meaning there for them and their family. But it's times like this when we are faced with these types of questions that the conversation shifts away from medicine to meaning. And in the moment, being present mattered way more than the treatment. What do you do when you are faced in this type of situation? And as we said in the beginning, and as Caleb has said, many of these things happened so quick. Sometimes you just need to have a minute or two. If you spend 1 minute or two with a patient, you save yourself so much more time. Just slow down and ask, or tell them, I can see how much you are going through right now. Name the reality, but be gentle, especially when they ask the timing. You can just say, things are more serious than we hoped. Don't rush the prognosis of the patient. Avoid to give them answers about days to weeks and things. I really don't know how people get that as well. Just say, I'm very worried, but we might be running out of time. Anchor them, reassure them that we will be in this moment with them. As I said, the families won't remember our explanations, but they will remember how we made them feel. That question from the child, they are probably some of the moments that I think we as physicians and pediatricians, we fear that the most. Because there's no correct answer. There's no textbook answer that tells you what to say. I read this thing about this girl that was worried about worried about dying. And in the end, when they asked her, but what are you scared of? Well, she said, well, I'm scared of the worms that's going to eat me when they bury me underground. So they came up with a contract and whole thing and made sure that she's going to be buried in a tin or a steel coffin that the worms can't get in. All of a sudden, she went to sleep and she had the most peaceful and amazing last few weeks of her life. What we should not do is, because especially when we panic, we want to fix things, we want to explain more, and we are actually avoiding the patients. It's very important not to give the patients false reassurance with answers like, yes, you'll be fine, saying that to the child, but then another thing to the parents. So don't, and also, if you're giving a patient the harsh honesty, make sure that there's somebody else there that will be able to support them. Because like an EMS person is going to leave. If you're just the registrar, the doctor on call at night, this is not your responsibility. What to say? What the family really needs in these situations is presence, honesty, and guidance. We need to acknowledge that this is really an important question if they ask. Allow pauses of 3 seconds in between. Like the little girl about the worms that's going to eat her, ask gently, what makes you ask this question? So it actually might reveal that they actually already know. The most important thing is be truthful, but give a safe answer. So if you are uncertain about what's going to happen, just tell the child, we are worried, we are doing everything that we can do to help your body get better. And if dying, say to him, we are very worried that your body is getting too tired to get better. But provide emotional safety. You are not alone. We are all right here with you. If you don't remember anything from today's talk, remember these things. These are like, I found them and it's like, wow, this is actually some nice things that we forget. There is actually certain little things that we can use where that you are not alone. There's many small little things that actually has got a lot of meaning for these patients. So remember these phrases. in moments when, what matters most in these moments, and I've heard lots of talks, and I'm gonna mention the spikes and things, methods and guidelines a little bit later. If you don't understand what a family is going through, no framework is going to save you. No framework is going to save you. I've been in situations where parents burst into tears, and my senior at the time just sat there. There was no touching, there was no nothing. He was just looked like the most uncomfortable person in the room. So no framework will save you, because it was probably the staying present that he thought that was what he was doing, but it definitely wasn't. And the people, afterwards, I was not even part of that team. Then you get there on a weekend ward round, and I get 20 plus questions. I'm like, but the head of the unit is your oncologist, and he knows better what you do. And you say, well, we understand you more and we trust you more. And I'm like, this is coming from the person for whom English is not his first language. They'd rather talk to me than to that person. Families experience, they are very overwhelmed in these situations when they are faced with these types of conversations and things. So you need to validate their emotions. It is essential, because, as you can see, they're experiencing a whole lot of fear and shock. You overload them with information, but sometimes they actually ask for a whole lot of information. I was in that situation this afternoon with this newly diagnosed with kidney cancer, and that mom, you just says, was like extremely overwhelmed, tearing, and it's like, what now, what next, and things as well, because obviously for them, they've now lost control, because there's other people telling them what is going to happen to this poor child. So give them time. These are lots of emotions that they are going through. The core principle is, and I think what is important as we as doctors, we definitely speak way too quickly in a crisis, okay? Because we are trying to tick the boxes and we're trying to give as much information. Yes, we are in a hurry. We've got so much to do. But we forget to just pause before we speak, acknowledge the parent, the child's emotion, focus on comfort, meaning, and togetherness. And then you proceed. As I said, frameworks don't replace humanity. It protects you, though. It protects humanity, though, when pressure is high. So that also helps. Like I said, sometimes pressure, you go into a pressure situation and then the whole meaning of the conversation changed. So I think, and what Caleb has said, when everything is falling apart and you're in a crisis situation, spikes is definitely not the first thing that you think. You might think of it, but as I see with my medical students, they can't even remember what the S and the this and the that stands for. For me, the most important thing is sit down, be honest, name the emotion of the patient, and stay. Be present. And that makes it, for me, that is more usable under pressure. Just to plainly go sit down, be honest with them. If they're emotional, name the emotion and stay in the moment with them. The nurses The NURSE acronym is How to Respond to Emotions, and it is definitely used in palliative communication. And as I said, every single time, and it's come up with that you need to name the emotion that the patient or the parent is feeling. Understand the feeling, respect them, allow them to feel what they feel. And as I said, if you're not prepared or don't have enough support with you at the time, rather wait and make sure, explore their concerns. Ask what they want to know, because sometimes you just give them the whole lot of wrong. How do they say? Sometimes you gave, well, is they got the wrong end of the stick, but other times you actually gave them the wrong end of the stick. Like the golden rules, these are very practical phrases that can be used in difficult moments. I wish we had better treatments for you, for your patient. Tell me what matters most for your family, and ask them, what worries you now? And yeah, so these are phrases that is very important for these patients. In the palliative care domain, I think what happens is, and I think that's what my patient felt when because yeah, my unit is what we call a country unit. My patients come from far away. So she was in Welkom seeking other help in Johannesburg, and they were just sent home. So they have a big fear of feeling abandoned. And we also, and they need to remember that hope doesn't disappear. It just it changes shape. We just need to think differently. We are now not curing, we are making the patient comfort. So there is comfort care, there is supportive care that you give the patient. Yes, survival versus meaningful time. We are adding meaningful time and adding quality of life to this patient's life as well. So in the palliative care, so you shade of the yard. Hope doesn't disappear, it just changes shape. And this is one thing that Sue has reminded me, but for me, this has actually been one of the most amazing tools that we've got. And if you think of it, the best crisis conversation is the one that you prepared for. What I've seen is that I see many doctors, and it's not only at the end of life. My poor mom was admitted in hospital, and she's a diabetic and starting to forget a lot of things as well. And here comes the dietitian, and she's having a half an hour conversation to my mom without anything for my mom to touch or to feel or to, it's just words going in and out, and she now can't remember anything. And my dad's 80. How much will he remember? And I was just going to ask that girl, okay, is that how you are earning your money? By actually wasting my parents'? But advanced care plans, this is amazing. It clarifies the goals of care, so you are prepared ahead of time, and you tell them why. It reduces the crisis decision making because it's been made before time as well. But you involve the family in this whole process where you share with them, okay, in this situation, where do you want me to go? What do we do? We were going to admit a 5-year-old little girl into an old age home, into a local town, because that was going to be the most appropriate place where she would have been nursed. And this was a community getting together as well. And if you plan ahead of time, the goals of care aligns with what you and the family wants during the time. So there is many conversations that one must have, and what is important whilst setting up. Yes, you can go and set up it before the time as well, but during the discussions and during the changes that you make, you need to check with the family, what do they actually understand about their illness? What is their biggest fears? What brings their child joy or comfort? What is their goals for care? And one of the reasons why this little girl had to go to the old age home is these parents said, listen, we won't be able to care for her at home. We're too poor. We've got a bachelor's flat and we are already 5 people living there. Having to care for somebody dying there, we won't be able to go back. So, and then always check what medical interventions align with the goals. And then, as I've said and mentioned, what is their preferred place of care for these patients? So this is just another summary because I find this actually very valuable, that you need to just plan the next steps together, share information clearly with the families, always make sure what do they understand about this, and explore what their values and goals are. During all of this, we must remember ourselves. You cannot, in your heart, you cannot hold space for families if there's no one holding space for you. So we need to care and support to each other. And people always say you must be like a robot, cut yourself off and things as well. But there's reasons why these conversations stay with you. It's not because you failed as a doctor, because you showed emotion. It's actually because you cared. That's why. That's why the deep breathing, acknowledging that these things does happen, knowing that these are emotionally demanding, support each other. My colleague Mampoy, she goes running. I play tennis. I garden. We do a lot of things that where you must look after yourself. Back to my story. That one of the boy in the ICU, the mother asking the question and remembering what the boy asked previously, are my parents going to be okay? So what happened next was that she was holding the Bible and it fell open on her lap. And it fell open to his favorite Bible story, the one of David and Goliath. And when she read the story and she came to the piece where it was something about small people perform great wonders, in that moment, she found a peace, and he passed moments later. As doctors, we feel we must answer, we must be able to fix things, we must be able to explain everything that is happening. Sometimes families are not asking for certainty. They are just searching for meaning, for peace, something to hold on to. And sometimes in a moment, an answer might not come to you, and that's also okay. Because sometimes we just need to be in the moment, hold it, just be there. Presence can be enough. I'm going to leave you with this message. We cannot always change the outcome, but we can most definitely influence how families experience the final journey. With that, I thank you, and over to you, Sue and Sam.
Thank you so much, Jan, for that insightful webinar on communication. I think you've left many of us feeling emotional, heard. You left us and you've given us so much information to take with us that's going to help us with our communication with our children, with our families. I just want to say thank you. You can see that many people from the comments coming through have taken a lot from you. They've appreciated a lot of the information that you shared, and some of the insightful tools that you've given them to take with. So thank you so much, Jan.
It's a pleasure, Sam.
If there's any questions for Jan, feel free to ask him. He is an expert in his field.
I just want to say to that, I'm not I just happen to love what I do.
Definitely. You've got a compassion, you've got a passion for it, and it clearly shows.
We love you, Jan.
Jan, it's Amy.
Yeah. Hi, Amy.
Hi. That was incredible. I mean, you know, I've gone through my journey, and I just think that what you presented there was unbelievable. I wish that I had experienced the journey with someone with your insight. It would have been, I think, yeah. Anyway, I do have a question. How do you communicate when you have a pediatric patient that is nonverbal and you're unsure of the cognitive awareness? How do you make them feel safe?
I've got one like that at the moment. So Kelly is, she's nonverbal. I don't know, it's just one of those things, and I thank my mother for this, her love of people, that and how much she shared, and I saw that in my brother this past weekend as well. It goes about, and one thing I always say to my patients and students when I teach them is one must remember children's first language was body language.
Yeah.
And that's what they pick up on. So the presence, the way that you speak, the way that you acknowledge them as part of the conversation. So between me and Kelly's mom, we talk to Kelly as well. But yeah, she's not functioning on a really, there's no words that and she just makes noises and things, but we do see the smiles. So yeah, that's how we do. It's not easy. No, it's not easy. And it's, to me, I would as well, just sometimes you just need to have a conversation with yourself. And and in the end, it's you talking to them, and they are actually listening and then picking up way more from what you meant and felt. And it was so, humbling, amazing. We've got 2 trisomy 21 girls in our wards, and I do student teaching every day where they've got to present a case in front of me and things. And I don't know why this poor student, she wanted to be perfect. And I wanted her to be human, see the patient. And so she started crying. And there, what does little Putumani do? She gets up and gives her a hug. And that's what children do. So they pick up. I think one mustn't try and be something else that you're not, but acknowledge them in the moment. And that's what works for me. That's what I find.
Thank
I
you
don't
so
know
much.
that answers, but I try to be human in those situations and just keep on talking to them.
Thank you.
Yeah,
Thank you, Amy, for the. There's a question from Philippa. Philippa's question in brackets of other healthcare workers in your conversation. Example, PEDS ICU voices in a cancer best way forward.
Sam, I lost a lot of what you said.
Because my network's so bad.
Yeah, I'm sorry.
Jan, it says, how do
I'll
you
read
hold...
it to you.
Okay, go, Trey.
How do you hold different voices, in brackets, of other healthcare workers in your conversation? Example, the PICU voices in a cancer journey, especially when there's conflict of opinion in the best way forward.
We have many of those. We have many of those. And it's sometimes some of the conversations that we dread, because to try and get an oncology patient into the ICU, there's always, what is the prognosis? And you can almost predict what they are saying as well. For me, it goes about, let them ask the question and listen. First listen, and then I think acknowledge the question and just make sure that you understand their point of view. For me, it goes that because now you've acknowledged and you've given them a little bit of power, in the sense of, okay, I hear you. These are and then you give your side and reasons as well. Sometimes they actually do help a lot. And we find that the conversations are actually being done extremely well. I've been involved with our ICU consultant, despite the facts that, yeah, they will put you, you feel like you in front of the firing peloton, but with all the questions that you've got to answer. But I just tell myself, okay, his brain just works differently. And for him, he needs to get everything, all his ducks in a row as well. And okay, now that the ducks is in a row, okay, then we can start with a conversation as well. I think it's important to acknowledge and hear what they are saying, but then to go back and give your point of view, because yeah, we are all different and we see things differently. So with my students, I always ask what everybody else sees, because what they hear and what they experience in a certain situation might be something that you didn't consider at the time as well. And it actually, and then you can take a new decision based on the new information that you obtained at that time. For me, so it goes about just give them their voice. But yes, obviously we keep on fighting for our patients. So I will always put my patient's voice first. But one must hear, because they are the people that knows the best about the ICU. I'm not an ICU expert at all, and I need their inputs with a lot of things as well. And as long as they understand why this is important, then they can plan and actually assist you way better than if there is a big difference of opinion between the two of you.
Thanks, Jan. Great discussion there, and just too nice to hear from your perspective too, and how to deal with it. I know Sam is battling with her Wi-Fi, so I thought I would just step in and help a little bit there. And Jan, amazing feedback and comments in the chat. I wish I could read them all to you. I don't see any more questions at the moment, but just thank you. Great presentation. Thank you. Such a blessing to hear the empathy on the road that we walk is sometimes softer than the heartache put into words from Alida, Taylor, Pamela. Thank you, Prof. Cassandra, thanks so much, Prof. You're truly inspiring. Wish to grow and develop like you. Yasmin, touch, tone, time. These are important. And then Henning says, even more than the information, your being, kindness, gentleness is so special. Your references to your mother says a lot about you and your mother. May God bless your work.
Thank you, everyone. Yeah, over the weekend, one of the gentlemen, a farmer, he and my mom served on the school board, and he asked me, do I ever read the comments? Because yeah, sometimes somehow some of my patients post a lot of things, and I'm like, no, I rather not. And he just looked at me. He said, he showed his wife, and he said, "You may." Yeah. So that was like, okay, to me that was a good answer, and it was like, wow, I've always been inspired by you as a human being. Thank you for acknowledging me, because that was like what that meant to me. That yeah. So I was really appreciative of Jacques' comment this weekend.
Thank you, Jan. Very special.
Can I just also make a comment? I mean, Jan, I've known you for so long, and honestly, you always move me and touch me. So thank you so much for that. So many things have stayed with me that when you've presented. I just want to remind everybody that we do have a really good course on communication on our Patch Academy website. So please do, if you're looking for more guidance, there's a lot of information that both Caleb and Jan spoke about on our communication course as well. So please do consider taking, even if you just do that as a standalone course, please do go and have a look at that.
Thank you, Sue. Thank you, Jan, and thank you, Caleb. This has been so inspiring and very touching. And I just want to hand over to Busi to say thank you and to close. And at the same time, Sue is going to put up the survey in the chat. If you could do that, and I will also put the QR code on a presentation slide. So if you can just use that to complete the survey, it would be much appreciated. Over to you, Busi.
Thanks, Tracy, and I want to thank you and Sue for putting all this together to be, and it has come out to be such a successful and wonderful webinar. I'd like to thank you, Tracy, for doing all the introductions, and Sue for introducing the Patch Academy and mentioning the CPD points that we have. And this is, I know this is very encouraging to those who need CPD points. So yeah, our courses are accredited and they have a lot of CPD points. Thank you very much for both of you for working on the Patch Academy. Sam, thank you for coming up with the topic. I know it's been something that has been bothering you for a long time, because we all battle with communication, particularly communicating with children. Before I became a palliative care nurse, I didn't just care how I communicated. But then when I became a palliative care nurse, I began to understand how much communication is important, and particularly with children. And you have, particularly breaking bad news. What do you say to the child when you say, when the child asks you if he's going to die, what do you say? You know, so thanks very much, Sam, for coming up with this topic. And I want to thank Caleb for joining the palliative care community now. You are an EMS person, but you are now part and parcel of the palliative care community. And thanks for a very inspiring and thought-provoking talk when you spoke about the principles of communication and when do we apply them. And you know, it's nice to be in college and learn about all these things and they make sense. But when you come to the actual real life situation, everything just goes out of the mind or through the window. So it was good of you to remind us of person-centered care and that it is the client or the patient that is important here and not us, and for reminding us or just informing us that we need to give the control to the family, to the patient and the family, because we think we know everything, we know too much, and we simply just take over. So it's important to remember that it is not our journey. It is the journey of the patient and the family. And we need to give control back to them and allow them, very importantly, allow them to set the tone of communication. And that ours is to render a service. We should give service. Oh, Jan, our long friend. When I think of each time I think of you and see you, I always remember our conference in Cardiff and how much fun we had in Cardiff. So you have said so much that I don't want to spoil anything that you have said, but it has been important for you to share with us the phrases that we can use when we communicate with the patient, particularly the child, and with the families, because we simply become dumbstruck, you know, you don't know what to say. And for reminding us that we need to be in the moment. We must shift. You said, you know, this really touched me, that we should shift from medicine to meaning, and that we should slow down and empathize with the family. Always acknowledge the moment and that we should stay present. And as I say, it has been a very insightful and thought-provoking presentation. You have empowered us so much with all those phrases, because, you know, when you are in a difficult situation, as I have said, you know, the anxiety button is triggered and you simply forget everything that you have learned and you become a robot. So we needed those phrases, what to say when we find ourselves in those difficult situations. And the cases that you have shared with us are very insightful and thought-provoking. And as usual, you know, you always give real life situations, the situations that you have been involved in, the cases that you have dealt with in the past, and they give us so much empowerment. And I want to say thanks very much to you, and thanks to Caleb for taking all the time this evening to spend with us rather than sitting at table with your families or watching television. Thank you.
Thank you, Pussy. Those were such lovely words too. Okay, everyone, we just thank you for your time, your presence, and please do look out for our next webinar. It will be in the next quarter, and we will share it openly on all our social media. And if you do want to get in touch with us, our email addresses and numbers are there. So thank you everyone for joining, and we just want to wish you a lovely evening further.
Thank you, Tracy, and thanks to everyone.
Thank you, everybody.
Thank you and good night.